the walking evaluation or the gait analysis. Once we've established the static structures, it's time to see how they all move with each other. It's often surprising to see structures come together or fall apart when movement is added. Jenny McConnell explains this as dynamic flexibility, or the ability to use a range of motion of a joint in a performance of a physical activity at a normal rate of speed. I like how she adds at a normal rate of speed. So obviously there are some people who can walk or run with no problem, but when it comes to sprinting or walking slow, it may become a problem. Ideal gait begins with a single leg stance, which swings into a double leg support stance, then swings through a single leg stance once again. 60% of this gait is in stance, and 40% is in the swing. Can be divided into three main categories. The first is contact or heel strike, the second is mid stance, and the third is propulsion or toe off. There are 6 determinants of gait: pelvic rotation, pelvic tilt, lateral pelvic displacement, hip flexion, knee flexion, and knee and ankle inversion. If a person is lacking on one of these determinants, a compensatory action may result. Take, for example, a patient with an amputated foot. They're quite able to walk, or a person missing 2 or more determinants may struggle more to compensate. So if you have an ankle or a knee that are both amputated, then obviously you're going to have a little bit more problem ambulating. Pelvic range of motion. Typical pelvic range of motion: lateral tilt is 4 degrees, rotation of 10 degrees, and AP lateral tilt of 7 degrees. As with lateral tilt and AP lateral tilt, 4 and 7 degrees are quite minute. Any detected movement in lateral tilt or AP lateral tilt can indicate weak gluteal muscles, a pelvic or a pelvic posterior tilt. Weak gluteals can also demonstrate with increased pelvic rotation. So 10 degrees you'll see a little bit more, but with increased you can tell that weak gluteal muscles. Swing phase. This is the pelvic and hip forward rotate 40 degrees. The lower leg internally rotates, then externally rotates. The foot begins in pronation to absorb the shock, then moves into supination for support. The muscle activity in late swing is gluteus maximus and tibialis anterior work eccentrically, while the soleus and the gastroc work at only about a fifth of their max. Gait can be described as a series of falls and very little muscle activity when walking normally. As the pace increases, so does the muscle action. Heel strike to mid stance. The pelvis shifts laterally into weight-bearing side about 25 millimeters. First, the TFL activates, followed by the gluteus medius during hip extension. The lower leg internally rotates. The knee slightly flexes through an eccentric quadriceps activity, and the foot moves into subtalar joint pronation to create a subtalar joint supination to create a stable lever for push-off. Heel off to toe off. Calcaneus is inverted about 4 to 6 degrees. Mid-stance to toe off, or to heel off. The lower leg externally rotates. The foot moves into calcaneal inversion of only about 2 degrees. The muscle activity consists of abductor hallucis, the flexor digitorum brevis, to increase stability. Tibialis posterior is synergistic to the peroneus longus, while the tibialis anterior acts more of an antagonist to the peroneus longus. So heel off to toe off, the calcaneus inverts 4 to 6 degrees. Muscle action begins with gastroc soleus activity and supportive, not propulsive action. This is followed by quadriceps activity in the middle fibers of the glute maximus. Once again, muscle activity increases when the pace increases. The potential for training, so where your rehabilitation would occur, it occurs in mid-stance muscle activity. This is a chance for intervention. The tibialis posterior resupinates the subtalar joint neutral and raises the base of the 5th metatarsal. So training this tibialis posterior will help strengthen those muscles. Peroneus longus stabilizes the 1st metatarsal as well. So obviously, and the flexor hallucis longus stabilizes the first toe. Um, both of these exercises are a little harder to do. It causes the adduction of the great toe, which is quite hard. If the tibialis posterior doesn't work for the peroneus longus, it will destabilize it. So if the tibialis posterior doesn't fire, then the peroneus longus will destabilize that. So it's important to work those muscles.